Anatomy of forearm and hand. Introduction. Forearm extends between the elbow and the wrist joints. Radius and ulna form its skeleton. These two bones articulate at both their ends to form superior and inferior radioulnar joints. Their shafts are kept at optimal distance by the interosseous membrane. Muscles accompanied by nerves and blood vessels are present both on the front and the back of the forearm. Hand is the most distal part of the upper limb, meant for carrying out diverse activities. Numerous muscles, tendons, bursae, blood vessels, and nerves are artistically placed and protected in this region. Surface landmarks of front and sides of forearm. 1. The epicondyles of the humerus have been examined. Note that medial epicondyle is more prominent than the lateral. The posterior surface of the medial epicondyle is crossed by the ulnar nerve, which can be rolled under the palpating finger. Pressure on the nerve produces tingling sensations on the medial side of the hand, see Fig 8.13. 2. The tendon of the biceps brachii can be felt in front of the elbow. It can be made prominent by flexing the elbow joint against resistance. Pulsations of the brachial artery can be felt just medial to the tendon, see Fig 8.18. The heat of the radius can be palpated in a depression on the posterolateral aspect of the extended elbow, distal to the lateral epicondyle. Its rotation can be felt during pronation and supination of the forearm. 4. The styloid process of the radius project 1 cm lower than the styloid process of the ulna, Fig 9.1. It can be felt in the upper part of the anatomical snuff box. Its tip is concealed by the tendons of the abductor pollicis longus and the extensor pollicis brevis, which must be relaxed during palpation. 5. The head of the radius forms a surface elevation on the medial part of the posterior surface of the wrist when the hand is pronated. 6. The styloid process of phi ulna projects downwards from the posteromedial aspect of the lower end of the ulna. Its tip can be felt on the posteromedial aspect of the wrist, where it lies about 1 cm above the tip of the styloid process of the radius, Fig 9.1. 7. The pisiform bone can be felt at the base of the hypothenar eminence, medially, where the tendon of the flexor carpi flexoris terminates. It becomes visible and easily palpable at the medial end of the distal transverse crease, junction of forearm and hand, when the wrist is fully extended. 5. The hook of the hamate lies 1 finger breadth below the pisiform bone, in line with the ulnar border of the ring finger. It can be felt only on deep palpation through the hypothenar muscles. 6. The tubercle of the scaphoid lies beneath the lateral part of the distal transverse crease in an extended wrist. It can be felt at the base of the thenar eminence in a depression just lateral to the tendon of the flexor carpi radialis, Fig 9.2. 7. The tubercle, crest, of the trapezium may be felt on deep palpation anterolateral to the tubercle of the scaphoid. 8. The brachioradialis becomes prominent along the lateral border of the forearm when the elbow is flexed against resistance in the mid-prone position of the hand. 9. The tendons of the flexor carpi radialis, palmaris longus, and /exor carpi ulnaris can be identified on the front of the wrist when the hand is flexed against resistance. The tendons lie in the order stated, from lateral to medial side, Fig 9.3. 10. The pulsation of the radial artery can be felt in front of the lower end of the radius just lateral to the tendon of the flexor carpi radialis. 11. The pulsations of the ulnar artery can be felt by careful palpation just lateral to the tendon of the flexor carpi ulnaris. Here the ulnar nerve lies medial to the artery. 12. The transverse creases in front of the wrist are important landmarks. The proximal transverse crease lies at the level of the wrist joint, and distal crease corresponds to the proximal border of the flexor retinaculum. 12. The median nerve is very superficial in position at and above the wrist. It lies along the lateral edge of the tendon of the palmaris longus at the middle of the wrist. Dissection. The skin of the forearm has already been reflected on each side. Cut through the superficial and deep fasciae to expose the superficial muscles of the forearm. Identify these 5 superficial muscles. These are from lateral to medial side, pronator arteries getting inserted into middle of radius, flexor carpi radialis reaching till the wrist, palmaris longus continuing with pulvinar aponeurosis, flexor digitorum superficialis passing through the palm and most medially the flexor carpi ulnaris getting inserted into the pisiform bone, Fig 9.3. Deep muscles. Cut through the origin of superficial muscles of forearm at the level of medial epicondyle of humerus and reflect them distally. This will expose the three deep muscles, e.g. flexor pollicis longus, flexor digitorum profundus and pronator quadratus. Components. The front of the forearm present the following components for study: 8 muscles, 5 superficial and 3 deep. 3 arteries. Radial and ulnar. 4 nerves, median, ulnar, and radial. These structures can be better understood by reviewing the long bones of the upper limb and having an articulated hand by the side. Superficial muscles. The muscles of the front of the forearm may be divided into superficial and deep groups. There are 5 muscles in the superficial group. These are the pronator teres, the flexor carpi radialis, the palmaris longus, the flexor carpi ulnaris and the flexor digitorum superficialis, tables 9.1 and 9.2. Common flexor origin. All the superficial flexors of the forearm have a common origin from the front of the medial epicondyle of the humerus. This is called the common flexor origin. Additional features of superficial muscles. Pronator teres. Pronator teres comprises a big humeral and a smaller ulnar head. Between the two heads median nerve leaves the cubital fossa. Deep to the two heads exits ulnar artery from cubital fossa into the front of forearm. It forms medial boundary of the cubital fossa. It is the pronator of forearm, see Fig 8.19. 2 flexor carpi radialis, it passes through a separate deep compartment of the flexor retinaculum. Flexor carpi radialis gets inserted into anterior aspects of bases of second and third metacarpal bones. It is easily seen and is a guide to radial pulse which lies lateral to the tendon. Palmaris longus. Palmaris longus continues as pulvinar aponeurosis into the palm to protect the nerves and vessels there. Its tendon lies superficial to flexor retinaculum. 4 flexor carpi ulnaris, it is inserted into pisiform bone. Pisiform is a sesamoid bone in this tendon. 5 flexor digitorum superficialis, flexor digitorum superficialis comprises the humerulnar and radial heads. The two heads of the muscle are joined by a fibrous arch. Median nerve and ulnar artery pass downwards deep to the fibrous arch, Fig 9.4. Deep muscles. Deep muscles of the front of the forearm are the flexor digitorum profundus, the flexor pollicis longus and the pronator quadratus and are described in additional points about the flexor digitorum profundus. 1. It is the most powerful, and most bulky muscle of the forearm. It forms the muscular elevation seen and felt on the posterior surface of the forearm medial to the subcutaneous posterior border of the ulna, Fig 9.4. 2. The main gripping power of the hand is provided by the flexor digitalis profundus. 3. The muscle is supplied by 2 different nerves. So it is a hybrid muscle. Additional points about the flexor pollicis longus. The anterior interosseous nerve and vessels descend on the anterior surface of the interosseous membrane between the flexor digitorum profundus and the flexor pollicis longus, Fig 9.5. 2. The tendon passes deep to the flexor retinaculum between the opponens pollicis and the oblique head of the adductor pollicis, to enter the fibrous flexor sheath of the thumb. It lies in radial bursa, Fig 9.6. Synovial sheaths of flexor tendons. 1. Common flexor synovial/sheath, ulnar BBRSD. The long flexor tendons of the fingers, flexor digitorum superficialis and profundus, are enclosed in a common synovial sheath while passing deep to the flexor retinaculum, carpal tunnel. The sheath has a parietal layer lining the walls of the carpal tunnel, and a visceral layer closely applied to the tendons, Fig 9.7. From the arrangement of the sheath it appears that the synovial sac has been invaginated by the tendons from its lateral side. The synovial sheath extends upwards for 5.0 or 7.5 centimeters into the forearm and downwards into the palm up to the middle of the shafts of the metacarpal bones. It is important to note that the lower medial end is continuous with the digital synovial sheath of the little finger. 2. Synovial sheath of the tendon of flexor pollicis jorges, radial horse. The sheath is separate. Superiorly, it is coextensive with the common sheath, and inferiorly it extends up to the distal phalanx of the thumb, Fig 9.6. Digital synovial sheaths. The sheaths enclose the flexor tendons in the fingers and line the fibrous flexor sheaths. The digital sheath of the little finger is continuous with the ulnar bursa, and that of the thumb with the radial bursa. However, the digital sheaths of the index, middle, and ring fingers are separate and independent, Fig 9.7. Vincula longa and brevia. The vincula longa and brevia are synovial folds, similar to the mesentery, which connect the tendons to the phalanges. They transmit vessels to the tendons, Fig 9.8. These are the remnants of mesotendon. The arteries. Dissection. Having dissected the superficial and deep group of muscles of the forearm, identify the terminal branches of the brachial artery, e.g. ulnar and radial arteries and their branches. Radial artery follows the direction of the brachial artery. Ulnar artery passes obliquely deep to heads of arteries and then runs vertically till the wrist. Carefully look for common interosseous branch of ulnar artery and its anterior and posterior branches. Features. The most conspicuous arteries of the forearm are the radial and ulnar arteries. However, they mainly supply the hand through the deep and superficial pulvinar arches. The arterial supply of the forearm is chiefly derived from the common interosseous branch of the ulnar artery, which divides into anterior and posterior interosseous arteries. The posterior interosseous artery is reinforced in the upper part and replaced in the lower part by the anterior interosseous artery. Radial artery. Beginning, course and termination. Radial artery, Fig 9.9, is the smaller terminal branch of the brachial artery in the cubital fossa. It runs downwards to the wrist with a lateral convexity. It leaves the forearm by turning posteriorly and entering the anatomical snuff box. As compared to the ulnar artery, it is quite superficial throughout its whole course. Its distribution in the hand is described later. Relations. 1. Anteriorly, it is overlapped by the brachioradialis in its upper part, but in the lower half it is covered only by skin, superficial and deep fasciae. 2. Posteriorly, it is related to the muscles attached to anterior surface of radius, i.e. biceps brachii, flexor pollicis longus, flexor digitorum superficialis and pronator quadratus. 3. Medially, it is related to the pronator teres in the upper one-third and the tendon of the flexor carpi radialis in the lower two-thirds of its course, Figs 9.9 and 9.10. 4. Laterally, brachioradialis in the whole extent and the radial nerve in the middle one-third. 5. The artery is accompanied by venae comitants. Branches in the forearm. 1. The radial recurrent artery arises just below the elbow, runs upwards deep to the brachioradialis, and ends by anastomosing with the radial collateral artery, anterior branch of profunda brachii artery, in front of the lateral epicondyle of the humerus, see Fig 8.10. 2 muscular branches are given to the lateral muscles of the forearm. 3. The pulvinar carpal ferdiicna rises near the lower border of the pronator quadratus, runs medially deep to the flexor tendons, and ends by anastomosing with the pulvinar carpal branch of the ulnar artery, in front of the middle of the recurrent branch of the deep pulvinar arch, to form a cruciform anastomosis. The pulvinar carpal arch supplies bones and joints at the wrist. 4. Dorsal carpal branch. It forms dorsal carpal arch with branch of ulnar artery. 5. The superficial pulvinar branch arises just before the radial artery leaves the forearm by winding backwards. The branch passes through the thenar muscles, and ends by joining the terminal part of the ulnar artery to complete the superficial pulvinar arch. Ulnar artery. Beginning, course and termination. Ulnar artery is the larger terminal branch of the brachial artery, and begins in the cubital fossa, Fig 9.10. The artery runs obliquely downwards and medially in the upper one-third of the forearm, but in the lower two-thirds of the forearm its course is vertical, Fig 9.4. It enters the palm by passing superficial to the flexor retinaculum. Its distribution in the hand is described later. Relations. 1. Anteriorly, in its upper half, the artery is deep and is covered by muscles arising from common flexor origin and median nerve. The lower half of the artery is superficial and is covered only by skin and fascia, Fig 9.4. 2. Posteriorly, it lies on brachialis and on the flexor digitorum profundus. 3. Medially, it is related to ulnar nerve and to the flexor carboradialis. 4. Laterally related to flexor digitorum superficialis. 5. The artery is related to vena comitans. Branches. 1. The anterior and posterior ulnar recurrent arteries anastomose around the elbow. The smaller anterior ulnar recurrent artery runs up and ends by anastomosing with the inferior ulnar collateral artery in front of the medial epicondyle. The larger posterior ulnar recurrent artery arises lower than the anterior and ends by anastomosing with the superior ulnar collateral artery behind the medial epicondyle, see Fig 8.11. 2. The common interosseous artery, about 1 cm long, arises just below the radial tuberosity. It passes backwards to reach the upper border of the interosseous membrane, and end by dividing into the anterior and posterior interosseous arteries. The anterior interosseous artery is the deepest artery on the front of the forearm. It accompanies the anterior interosseous nerve. It descends on the surface of the interosseous membrane between the flexor digitorum profundus and the flexor pollicis longus, Fig 9.5. It pierces the interosseous membrane at the upper border of the pronator quadratus to enter the extensor compartment. The artery gives muscular branches to the deep muscles of the front of the forearm, nutrient branches to the radius and ulna, and a median artery which accompanies the median nerve. Near its origin, the posterior interosseous artery gives off the interosseous recurrent artery which runs upwards, and ends by anastomosing with middle collateral artery, posterior branch of profunda brachii artery, behind the lateral epicondyle. 3 vascular branches supply the medial muscles of the forearm. The dorsal carpal branch arises just above the pisiform bone, winds backwards deep to the tendons, and ends in the dorsal carpal arch. This arch is formed medially by the dorsal carpal branch of the ulnar artery, and laterally by the dorsal carpal branch of the radial artery. The nerves. Dissection. Median nerve is the chief nerve of the forearm. It enters the forearm by passing between two heads of pronator teres muscle. Its anterior interosseous branch is given off as it is leaving the cubital fossa. Identify median nerve stuck to the fascia on the deep surface of flexor digitorum superficialis muscle. Thus, the nerve lies superficial to the flexor digitorum profundus, Fig 9.4. Dissect the anterior interosseous nerve as it lies on the interosseous membrane between flexor pollicis longus and flexor digitorum profundus muscles, Fig 9.4. Identify the ulnar nerve situated behind the medial epicondyle. Trace it vertically down till the flexor retinaculum. Trace the radial nerve and its 2 branches in the lateral part of the cubital fossa. Its deep branch is muscular and superficial branch is cutaneous, Fig 9.4. Nerves of the front of the forearm are the median, ulnar, and radial nerves. The radial and ulnar nerves run along the margins of the forearm, and are never crossed by the corresponding vessels which gradually approach them. The ulnar artery, while approaching the ulnar nerve, gets crossed by the median nerve, Fig 9.10. Median nerve. Median nerve is the main nerve of the front of the forearm. It also supplies the muscles of thenar eminence, Fig 9.10. The median nerve controls coarse movements of the hand, as it supplies most of the long muscles of the front of the forearm. It is, therefore, called the laborer's nerve. Coarse. Median nerve lies medial to brachial artery and enters the cubital fossa. It is the most medial content of cubital fossa, Fig 9.11. Then it enters the forearm to lie between flexor digitorum superficialis and flexor digitorum profundus. It lies adherent to the back of superficialis muscle. Then it reaches down the region palmar and dorsal carpal branches take part in the anastomosis round the wrist joint. The palmar carpal branch helps to form the palmar carpal arch of wrist where it lies deep and lateral to palmaris longus tendon. Lastly, it passes deep to flexor retinaculum through carpal tunnel to enter the palm, Fig 9.12. Relations 1. In the cubital fossa, median nerve lies medial to the brachial artery, behind the bicipital aponeurosis, and in front of the brachialis. 2. The median nerve enters the forearm by passing between the two heads of the peroneate arteries. Here it crosses the ulnar artery, from which it is separated by the deep head of the peroneate arteries, Fig 9.11. 4. Along with the ulnar artery, the median nerve passes beneath the fibrous arch of the flexor digitorum superficialis, and runs deep to this muscle on the surface of the flexor digitorum profundus. It is accompanied by the median artery, a branch of the anterior interosseous artery. About 5 cm above the flexor retinaculum, wrist, it becomes superficial and lies between the tendons of the flexor carpi radialis, laterally, and the flexor digitorum superficialis, medially. It is overlapped by the tendon of the palmaris longus, Fig 9.6. The median nerve enters the palm by passing deep to the flexor retinaculum through the carpal tunnel. Branches. 1. Muscular branches are given off in the cubital fossa to flexor carpi radialis, palmaris longus, and flexor digitorum superficialis, Fig 9.12. 2. The anterior interosseous branch is given off in the upper part of the forearm. It supplies the flexor pollicis longus, the lateral half of the flexor digitorum profundus, giving rise to tendons for the index and middle fingers, and the peroneator quadratus. The nerve also supplies the distal radioulnar and wrist joints, Fig 9.12. 3. The posterior interosseous branch arises a short distance above the flexor retinaculum ies superficial to it and supplies the skin over the thenar eminence and the central part of the palm. 4. Articular branches are given to the elbow joint and to the proximal radioulnar joint. 5. Vascular branches supply the radial and ulnar arteries. 6. A communicating branch is given to the ulnar nerve. Ulnar nerve. The ulnar nerve is also known as the musician's nerve because it controls fine movements of the fingers. Its course in the palm will be considered in the later part of this chapter. Course. Ulnar nerve is palpable as it lies behind medial epicondyle of humerus and is not a content of cubital fossa, Fig 9.13a. It enters the forearm by passing between two heads of flexor carpi ulnaris, i.e. cubital tunnel, to lie along the lateral border of flexor carpi ulnaris in the forearm. In the last phase, it courses superficial to the flexor retinaculum, covered by its superficial slip or volar carpal ligament to enter the region of palm. Relations. 7. At the elbow, the ulnar nerve lies behind the medial epicondyle of the humerus. It enters the forearm by passing between the two heads of the flexor carpi ulnaris, Fig 9.13a. 8. In the forearm, the ulnar nerve runs between the flexor digitorum profundus medially and the flexor digitorum superficialis laterally. 9. At the wrist, the ulnar neurovascular bundle lies between the flexor carpi ulnaris and the flexor digitorum superficialis. The bundle enters the palm by passing superficial to the flexor retinaculum, lateral to the pisiform bone. Branches. 1. Muscular, to the flexor carpi ulnaris and the medial half of the flexor digitorum profundus. 2. Pulvinar cutaneous branch arises in the middle of the forearm and supplies the skin over the hypothenar eminence, Fig 9.13a. 3. Dorsal cutaneous branch arises 7.5 cm above the wrist, winds backwards and supplies the proximal parts of the medial 21/Z fingers and the adjoining area of the dorsum of the hand. 4. 4 articular branches are given to the elbow joint. 5 at S branches in the palm are shown in this fig. Radial nerve. Course. The radial nerve divides into its two terminal branches in the cubital fossa just below the level of the lateral epicondyle of the humerus, Fig 9.4. Branches. The deep terminal branch, posterior interosseous, soon enters the back of the forearm by passing through the supinator muscle. The superficial terminal branch, the main continuation of the nerve, runs down in front of the forearm. The superficial terminal branch of the radial nerve is closely related to the radial artery only in the middle one-third of the forearm, Fig 9.10. 10 in the upper one-third, it is widely separated from the artery, and in the lower one-third it passes point 12 backward under the tendon of the brachioradialis. 11. The superficial terminal branch is purely cutaneous and is distributed to the lateral half of the dorsum of the hand, and to the proximal parts of the dorsal surfaces of the thumb, the index finger, and lateral half of the middle finger. Injury to this branch results in small area of sensory loss over the root of the thumb dissection. A horizontal incision at the distal crease of front of the wrist has already been made. Make a vertical incision from the center of the above incision through the palm to the center of the middle finger, Fig 9.14. Make one horizontal incision along the distal palmar crease. Make an oblique incision starting 3 cm distal to incision No. 2 and extend it till the tip of the distal phalanx of the thumb. Thus the skin of the palm gets divided into 3 areas. Reflect the skin of lateral and medial flaps on their respective sides. The skin of the intermediate flap is reflected distally towards the distal palmar crease. Further, the skin of middle finger is to be reflected on either side. Superficial fascia and deep fascia. Remove the superficial fascia to clean the underlying deep fascia. Deep fascia is modified to form the flexor retinaculum at wrist, palmar aponeurosis in the palm, and fibrous flexor sheaths in the digits. Identify the structures on its superficial surface. Divide the flexor retinaculum between the thenar and hypothenar eminences, carefully preserving the underlying median nerve and long flexor tendons. Identify long flexor tendons enveloped in their synovial sheaths, including the digital synovial sheaths. Features: the human hand is designed, for grasping, for precise movement, for serving as a tactile organs. There is a big area in the motor cortex of brain for muscles of hand. The skin of the palm is thick for protection of underlying tissues. Immobile because of its firm attachment to the underlying palmar aponeurosis. Creased. All of these characters increase the efficiency of the grip. The skin is supplied by spinal nerve C6, C7, C8, through the median and ulnar nerves. The superficial fascia of the palm is made up of dense fibrous bands which bind the skin to the deep fascia, palmar aponeurosis, and divide the subcutaneous fat into small tight compartments which serve as water cushions during firm gripping. The fascia contains a subcutaneous muscle, the palmaris brevis, which helps in improving the grip by steadying the skin on the ulnar side of the hand. The superficial metacarpal ligament, which stretches across the roots of the fingers over the digital vessels and nerves, is a part of this fascia. The deep fascia is specialized to form, I the flexor retinaculum at the wrist. 2 the palmar aponeurosis in the palm. The fibrous flexor sheaths in the fingers. All 3 form a continuous structure which holds the tendons in position and thus increase the efficiency of the grip. Flexor retinaculum. Flexor, Latin to hold, hoc. Retinaculum is a strong fibrous band which bridges the anterior concavity of the carpus and converts it into a tunnel, the carpal funnel, Fig 9.15. Attachment medially to one pisiform bone, one to the hook of the hamate. Laterally, to the tubercle of the scaphoid, and the crease of trapezium. On either side, the retinaculum has a slip. 1. The lateral deep slip is attached to the medial lip of the groove on the trapezium, which is thus converted into a tunnel for the tendon of the flexor carpi radialis. 2. The medial superficial slip, volar carpal ligament, is attached to the pisiform bone. The ulnar vessels and nerves pass deep to the slip, Figs 9.15 and 9.16. Relations: the structures passing superficial to the flexor retinaculum are, the palmar cutaneous branch of the median nerve. The tendon of the palmaris longus. The palmar cutaneous branch of the ulnar nerve. The ulnar vessels. The ulnar nerve. The thenar and hypothenar muscles arise from the retinaculum, Fig 9.15. The structures passing deep to the flexor retinaculum are, the median nerve. 3 tendons of the flexor digitorum superfacials. 4 tendons of flexor pollicis longus. 5 the ulnar bursa. 6 the radial bursa. The tendon of the flexor carpi radialis lies between the retinaculum and its deep slip, in the groove on the trapezium, Fig 9.15. Palmar aponeurosis. This term is often used for the entire deep fascia of the palm. However, it is better to restrict this term to the central part of the deep fascia of the palm, which covers the superficial pulvinar arch, the long flexor tendons, the terminal part of the median nerve, and the superficial branch of the ulnar nerve, Fig 9.16. Features. Pulvinar aponeurosis is triangular in shape. The apex, which is proximal, blends with the flexor retinaculum and is continuous with the tendon of the palmaris longus. The base is directed distally. It divides into superficial and deep strata. Superficial is attached to dermis. Deep strata divides into 4 slips opposite the heads of the metacarpals of the medial 4 digits. Each slip divides into 2 parts which are continuous with the fibrous flexor sheaths. Extensions pass to the deep transverse metacarpal ligament, the capsule of the metacarpophalangeal joints and the sides of the base of the proximal phalanx. The digital vessels and nerves, and the tendons of the lumbricals emerge through the intervals between the slips. From the lateral and medial margins of the pulvinar aponeurosis, the lateral and medial pulvinar septa pass backwards and divide the palm into compartments. Functions: pulvinar aponeurosis fixes the skin of the palm and thus improves the grip. It also protects the underlying tendons, vessels, and nerves. Fibrous flexor sheaths of the fingers. The fibrous flexor sheaths are made up of the deep fascia of the fingers. The fascia is thick and arched. It is attached to the sides of the phalanges and across the base of the distal phalanx. Proximally, it is continuous with a slip of the pulvinar aponeurosis. In this way, a blind osteovascular tunnel is formed which contains the long flexor tendons enclosed in the digital synovial sheath, Figs 9.17a to c. The fibrous sheath is thick opposite the phalanges and thin opposite the joints to permit flexion. The sheath hold the tendon in position during flexion of the digits. Dupuytren's contracture. This condition is due to inflammation involving the ulnar side of the pulvinar aponeurosis. There is thickening and contraction of the aponeurosis. As a result, the proximal phalanx and later the middle phalanx become flexed and cannot be straightened. The terminal phalanx remains unaffected. The ring finger is most commonly involved, Fig 9.18. Intrinsic muscles of the hand dissection. Clean the thenar and hypothenar muscles. Carefully preserve the median nerve and superficial and deep branches of ulnar nerve which supply these muscles. Abductor pollicis is the lateral muscle, flexor pollicis brevis is the medial one. Both these form the superficial lamina. The deeper lamina is constituted by apponens pollicis, Fig 9.19. Cut through the abductor pollicis to expose the apponens pollicis. These 3 muscles constitute the muscles of thenar eminence. Incise flexor pollicis brevis in its center and reflect its 2 parts. This will reveal the tendon of flexor pollicis longus and adductor pollicis on a deeper plane. The 3 muscles of thenar eminence are supplied by thick recurrent branch of median nerve. On the medial side of hand, identify thin palmaris brevis muscle in the superficial fascia. It receives a twig from the superficial branch of ulnar nerve. Hypothenar eminence is comprised by abductor digiti minimi medially, flexor digiti minimi just lateral to it. Deep to both these lies apponens digiti minimi. Identify these 3 muscles and trace their nerve supply from deep branch of ulnar nerve. Between the 2 eminences of the palm, deep to pulvinar aponeurosis, identify the superficial pulvinar arch formed mainly by superficial branch of ulnar and superficial pulvinar branch of radial artery. Identify its common and proper digital branches. Clean, dissect and preserve the branches of the median nerve and superficial division of ulnar nerve in the palm lying between the superficial pulvinar arch and long flexor tendons, Fig 9.20. Lying on a deeper plane are the tendons of flexor digitorum superficialis muscle. Dissect the peculiar mode of its insertion in relation to that of tendon of flexor digitorum profundus. Cut through the tendons of flexor digitorum superficialis 5 cm above the wrist. Divide both ends of superficial pulvinar arch, reflect them distally towards the metacarpophalangeal joints. Identify 4 tendons of flexor digitorum profundus diverging in the palm with 4 delicate muscles, the lumbricals arising from them. Dissect the nerve supply to these lumbricals. The first and second are supplied from median and third and fourth from the deep branch of ulnar nerve. Divide the flexor digit orum profundus 5 cm above the wrist and reflect it towards the metacarpophalangeal joints. Trace one on its tendons to its insertion into the base of distal phalanx of one finger. Features. The intrinsic muscles of the hand serve the function of adjusting the hand during gripping and also for carrying out fine skilled movements. The origin and insertion of these muscles is within the territory of the hand. There are 20 muscles in the hand. These are, 1a 3 muscles of thenar eminence. I abductor pollicis brevis. 2 flexor pollicis brevis. Opponens pollicis. B1 abductor of thumb adductor pollicis. 2 4 hypothenar muscles, 3 I palmaris brevis. 2 abductor digiti minimi. 2 flexor digiti minimi muscles, 2, 4, are muscles of hypothenar eminence. 4 lumbricoles. 4 palrunar interosseous. 5 T are dorsal interossei. Actions of thenar muscles. In studying the actions of the thenar muscles, it must be remembered that the movements of the thumb take place in planes at right angles to those of the other digits because the thumb, first metacarpal, is rotated medially through 90 degrees. Flexion and extension of the thumb take place in the plane of the palm, while abduction and adduction at right angles to the plane of palm. Movement of the thumb across the palm to touch the other digits is known as opposition. This movement is a combination of flexion and medial rotation. Actions of dorsal interossei. All dorsal interossei cause abduction of the digits away from the line of the middle finger. This movement occurs in the plane of palm, Fig 9.25, in contrast to the movement of thumb where abduction occurs at right angles to the plane of palm, Fig 9.26. Note that movement of the middle finger to either medial or lateral side constitutes abduction. Also note that the first and fifth digits do not require dorsal interossei as they have their own abductors. Testing of some intrinsic muscles. Pencil test for abductor pollicis brevis. Lay the hand flat on a table with the palm directed upwards. The patient is unable to touch with his thumb a pen/pencil held in front of the palm, Fig 9.27. Test for opponens pollicis. Request the patient to touch the proximal phalanx of second to fifth digits with the tip of thumb. See the dorsal interossei are tested by asking the subject to spread out the fingers against resistance. As index finger is abducted, one feels first dorsal interosseous, Fig 9.28. The palrunar interossei and adductor pollicis are tested by placing a piece of paper between the fingers, between thumb and index finger, Fig 9.29, and seeing how firmly it can be held, Fig 9.30. Moments sign or the book test, which tests the adductor pollicis muscle. When the patient is asked to grasp a book firmly between the thumb and other fingers of both the hands, the terminal phalanx of the thumb on the parallel side becomes flexed at the interphalangeal joint, by the flexor pollicis longus, which is supplied by the median nerve, Fig 9.31. The lumbricals and interossei are tested by asking the subject to flex the fingers at the metacarpophalangeal joints against resistance. Dissection. Deep to the lateral 2 tendons of flexor digit orum profundus muscle, note an obliquely placed muscle extending from 2 origins, i.e. from the shaft of the third metacarpal bone and the bases of second and third metacarpal bones and adjacent carpal bones to the base of proximal phalanx of the thumb. This is adductor pollicis. Reflect the adductor pollicis muscle from its origin towards its insertion, Fig 9.22. Identify the deeply placed interossei muscles. Identify the radial artery entering the palm between 2 heads of first dorsal interosseous muscle and then between 2 heads of adductor pollicis muscle, turning medially to join the deep branch of ulnar artery to complete the deep palrunar arch, Fig 9.32. Identify the deep branch of ulnar nerve lying in its concavity. Carefully preserve it, including its multiple branches. Deep branch of ulnar nerve ends by supplying the adductor pollicis muscle. It may supply deep head of flexor pollicis brevis also. Lastly, define 4 small palrunar interossei and 4 relatively bigger dorsal interossei muscles. Features. Arteries of the hand are the terminal parts of the ulnar and radial arteries. Branches of these arteries unite and form anastomotic channels called the superficial and deep pulvinar arches. Ulnar artery. The course of this artery in the forearm has been described earlier. It enters the palm by passing superficial to the flexor retinaculum but deep to volar carpal ligament, Fig 9.15. It ends by dividing into the superficial palmar branch, which is the main continuation of the artery, and the deep pulvinar branch. These branches take part in the formation of the superficial and deep pulvinar arches respectively. Superficial pulvinar arch. The arch represents an important anastomosis between the ulnar and radial arteries. The convexity of the arch is directed towards the fingers, and its most distal point is situated at the level of the distal border of the fully extended thumb. Formation. The superficial pulvinar arch is formed as the direct continuation of the ulnar artery beyond the flexor retinaculum, i.e. by the superficial pulvinar branch. On the lateral side, the arch is completed by superficial pulvinar branch of radial artery, Fig 9.32. Position. The superficial pulvinar arch lies deep to the palmaris brevis and the pulvinar aponeurosis. It crosses the palm over the flexor digiti minimi, the flexor tendons of the fingers, the lumbricals, and the digital branches of the median nerve. Superficial pulvinar arch gives off 3 common digital and 1 proper digital branches which supply the medial 3 1/2 fingers. The lateral 3 common digital branches are joined by the corresponding pulvinar metacarpal arteries from the deep pulvinar arch. The deep branch of the ulnar artery arises in front of the flexor retinaculum immediately beyond the pisiform bone. Soon it passes between the flexor and abductor digiti minimi to join and complete the deep pulvinar arch. Clinical anatomy. The radial artery is used for feeling the arterial pulse at the wrist. The pulsations can be felt well in this situation because of the presence of the flat radius behind the artery, Fig 9.10. Radial artery. In this part of its course, the radial artery runs obliquely downwards, and backwards deep to the tendons of the abductor pollicis longus, the extensor pollicis brevis, and the extensor pollicis longus, and superficial to the lateral ligament of the wrist joint. Thus it passes through the anatomical SNB hocks to reach the proximal end of the first interosseous space, Fig 9.33. Further, it passes between the 2 heads of the first dorsal interosseous muscle and between the 2 heads of adductor pollicis to form the deep pulvinar arch in the palm. Course. Radial artery runs obliquely from the site of radial pulse to reach the anatomical snuff box. From there it passes forwards to reach first interosseous space and then into the palm. Relations. 1. It leaves the forearm by winding backwards round the wrist. 2. It passes through the anatomical snuff box where it lies deep to the tendons of the abductor pollicis longus, the extensor pollicis brevis and the extensor pollicis longus. It is also crossed by the digital branches of the radial nerve. The artery is superficial to the lateral ligament of the wrist joint, the scaphoid and the trapezium. 3. It reaches the proximal end of the first interosseous space and passes between the 2 heads of the first dorsal interosseous muscle to reach the palm. 4. In the palm, the radial artery runs medially. At first it lies deep to the oblique head of the adductor pollicis, and then passes between the 2 heads of this muscle to form deep pulvinar arch. Therefore, it is known as the deep pulvinar arch, Fig 9.32. Branches dorsum of hand. On the dorsum of the hand, the radial artery gives off a branch to the lateral side of the dorsum of thumb. 2. The dorsal metacarpal artery. This artery arises just before the radial artery passes into the interval between the 2 heads of the first dorsal interosseous muscle. It at once divides into 2 branches for the adjacent sides of the thumb and the index finger. Palm. In the palm, deep to the oblique head of the adductor pollicis, the radial artery gives off 1. The princeps pollicis artery which divides at the base of the proximal phalanx into 2 branches for the pulvinar surface of the thumb. 2. The radialis indicis artery descends between the first dorsal interosseous muscle and the transverse head of the adductor pollicis to supply the lateral side of the index finger. Deep pulvinar arch. Deep pulvinar arch provides a second channel connecting the radial and ulnar arteries in the palm, the first one being the superficial pulvinar arch already considered. It is situated deep to the long flexor tendons. Formation: the deep pulvinar arch is formed mainly by the terminal part of the radial artery, and is completed medially at the base of the fifth metacarpal bone by the deep pulvinar branch of the ulnar artery. Relations: the arch lies on the proximal parts of the shafts of the metacarpals, and on the interossei, under cover of the oblique head of the adductor pollicis, the flexor tendons of the fingers, and the lumbricals. The deep branch of the ulnar nerve lies within the concavity of the arch. Branches: 1. From its convexity, i.e. from its distal side, the arch gives off 3 pulvinar metacarpal arteries, which run distally in the second, third, and fourth spaces, supply the medial 4 metacarpals, and terminate at the finger clefts by joining the common digital branches of the superficial pulvinar arch, Fig 9.32. 2. Dorsally, the arch gives off 3, proximal, perforating digital arteries which pass through the medial 3 interosseous spaces to anastomose with the dorsal metacarpal arteries. The digital perforating arteries connect the pulvinar digital branches of the superficial pulvinar arch with the dorsal metacarpal arteries. 3. Recurrent crunch arises from the concavity of the arch and pass proximally to supply the carpal bones and joints, and ends in the pulvinar carpal arch. Nerves. Ulnar nerve. Ulnar nerve is the main nerve of the hand, like the lateral plantar nerve in the foot. Course. Ulnar nerve lies superficial to flexor retinaculum, covered only by the superficial slip of the retinaculum. It terminates by dividing into a superficial and a deep branch. Superficial branch is cutaneous. The deep branch passes through the muscles of the hypothalamic eminence to lie in the concavity of the deep pulvinar arch to end in the adductor pollicis, Fig 9.22. Relations: 1. The ulnar nerve enters the palm by passing superficial to the flexor retinaculum where it lies between the pisiform bone and the ulnar vessels. Here the nerve divides into its superficial and deep terminal branches. 2. The superficial terminal branch supplies the palmaris brevis and divides into 2 digital branches for the medial 1/4 inch fingers. 3. The deep terminal branch accompanies the deep branch of the ulnar artery. It passes backwards between the abductor and flexor digiti minimi, and then between the opponens digiti minimi and the fifth metacarpal bone, lying on the hook of the hamate. Finally, it turns laterally within the concavity of the deep pulvinar arch. It ends by supplying the adductor pollicis muscle. Branches. From superficial terminal branch. 1. Muscular branch to palmaris brevis. 1. Cutaneous branches. 2. Pulvinar digital nerves supply the medial 1½ fingers with their nail beds. The medial branch supplies the medial side of the little finger. The lateral branch is a common pulvinar digital nerve. It divides into 2 proper pulvinar digital nerves for the adjoining sides of the ring and little fingers. The common pulvinar digital nerve communicates with the median nerve. Muscular branches. At its origin, the deep branch supplies 3 muscles of hypothalamic eminence. As the nerve crosses the palm, it supplies the medial 2 lumbricals and 8 interossei. The deep branch terminates by supplying the adductor pollicis, and occasionally the deep head of the flexor pollicis brevis. An articular branch supplies the wrist joint. Cl and calentomy. The ulnar nerve is also known as the musician's nerve because it controls fine movements of the fingers. The ulnar nerve is commonly injured at the elbow. Behind the medial epicondyle or distal to elbow as it passes between 2 heads of flexor carpi ulnaris, cubital tunnel, or at the wrist in front of the flexor retinaculum. Radial nerve injury at the elbow, flexor carpi ulnaris and the medial half of the flexor digitorum profundus are paralyzed. Due to this paralysis, the medial border of the forearm becomes flattened, Fig 9.36. An attempt to produce flexion at the wrist result in abduction of the hand. The tendon of the flexor carpi ulnaris does not tighten on making a fist. Flexion of the terminal phalanges of the ring and little fingers is lost, Figs 9.37 and 9.38, The ulnar nerve control line movement of the fingers through its extensive motor distribution to the short muscles of the hand. Ulnar nerve lesion at the wrist produces ulnar claw hand. Ulnar claw hand is characterized by the following signs: hyperextension at the metacarpophalangeal joints and flexion at the interphalangeal joints, involving the ring and little fingers more than the index and middle fingers, Fig 9.39. The little finger is held in extension by extensor muscles. The intermetacarpal spaces are hollowed out due to wasting of the interosseous muscles. Claw hand deformity is more obvious in wrist lesions as the profundus muscle is spared. This causes marked flexion of the terminal phalanges, action of paradox. Sensory loss is confined to the medial 1/3 of the palm and the medial 1½ fingers including their nail beds, Figs 9.40a and b. Medial half of dorsum of hand also shows sensory loss. Fig 9.36, flattening of medial border of forearm. Fig 9.37, distal interphalangeal joints of ring and little fingers remain extended. Fig 9.38, little finger remains extended at terminal phalanx. Vasomotor changes, the skin areas with sensory loss is warmer due to arteriolar dilatation, it is also drier due to absence of sweating because of loss of sympathetic supply. Trophic changes. Long-standing cases of paralysis lead to dry and scaly skin. The nails crack easily with atrophy of the pulp of fingers. The patient is unable to spread out the fingers due to paralysis of the dorsal interossei. The power of adduction of the thumb, and flexion of the ring and little fingers are lost. It should be noted that median nerve lesions are more disabling. In contrast, ulnar nerve lesions leave a relatively efficient hand. Median nerve. The median nerve is important because of its role in controlling the movements of the thumb, which are crucial in the mechanism of gripping by the hand. Course. Median nerve lies deep to flexor retinaculum in the carpal tunnel and enters the palm, Fig 9.15. Soon it terminates by dividing into muscular and cutaneous branches. Relations. 1. The median nerve enters the palm by passing deep to the flexor retinaculum, where it lies in the narrow space of the carpal tunnel in front of the ulnar bursa enclosing the flexor tendons. Immediately below the retinaculum the nerve divides into lateral and medial divisions, Fig 9.20. 2. The lateral division gives off a muscular branch to the thenar muscles, and 3 digital branches for the lateral 1½ digits including the thumb. The muscular branch curls upwards round the distal border O1 the retinaculum and supplies the thenar muscles. Out of the 3 digital branches, 2 supply the thumb and 1 the lateral side of the index finger. The digital branch to the index finger also supplies the first lumbrical, Fig 9.41. The medial division divides into 2 common digital branches for the second and third interdigital clefts supplying the adjoining sides of the index, middle, and ring fingers. The lateral common digital branch also supplies the second lumbrical. Branches in the hand. The median nerve supplies 5 muscles, namely the abductor pollicis brevis, the flexor pollicis brevis, the opponens pollicis and the first and second lumbrical muscles. Pulvinar skin over the lateral 3½ digits with their nail beds. The median nerve controls coarse movements of the hand, as it supplies most of the long muscles of the front of the forearm. It is, therefore, called the Forearm's nerve. It is also called eye of the hand as it is sensory to most of the hand. When the median nerve is injured above the level of the elbow, as might happen in supracondylar fracture of the humerus, the following features are seen. The flexor pollicis longus and lateral half of flexor digitorum profundus are paralysed. The patient is unable to bend the terminal phalanx of the thumb and index finger when the proximal phalanx is held firmly by the clinician, to eliminate the action of the short flexors, Fig 9.42. Similarly, the terminal phalanx of the middle finger can be tested. The forearm is kept in a supine position due to paralysis of the pronators. The hand is adducted due to the paralysis of the flexor carpi radialis, and flexion at the wrist is weak. Flexion at the interphalangeal joints of the index and middle fingers is lost so that the index, and to a lesser extent, the middle fingers tend to remain straight while making a fist. This is called pointing index finger occurs due to paralysis of long flexors of the digit, Fig 9.43, E-ape or monkey thumb deformity is present due to paralysis of the thenar muscles. The area of sensory loss corresponds to its distribution, Fig 9.45, in the hand. Vasomotor and trophic changes, the skin on lateral 3.5 digit is warm, dry, and scaly. The nails get cracked easily, Fig 9.46. Carpal tunnel syndrome, CTS. Involvement of the median nerve in carpal tunnel at wrist has become a very common entity, Fig 9.15. This syndrome consists of motor, sensory, vasomotor and trophic symptoms in the hand caused by compression of the median nerve in the carpal tunnel. Examination reveals wasting of thenar eminence, ape-like hand, hypoesthesia to light touch on the palmar aspect of lateral 31/2 digits. However, the skin over the thenar eminence is not affected as the branch of median nerve supplying it arises in the forearm. Froment's sign/book holding test, the patient is unable to hold the book with thumb and other fingers. Paper holding test, the patient unable to hold paper between thumb fingers. Digital branches which supply the skin of the digits as follows, see Fig 7.1. First, lateral side of thumb. Second, medial side of thumb. G3RD, lateral side of index finger. Fourth, contiguous sides of index and middle fingers. Note that skin over the dorsum of the distal phalanges is supplied by the median nerve, not radial, Fig 9.50. Sensory loss is less because of overlapping of nerves. Spaces of the hand. Having learned the anatomy of the whole hand, the clinically significant spaces of the hand need to be understood and their boundaries to be identified from the following text. The arrangement of fasciae and the facial septa in the hand is such that many spaces are formed. These spaces are of surgical importance because they may become infected and distended with pus. The important spaces are as follows: A. Palmar spaces. 1. Pulp space of the fingers. 2. Mid-palmar space. 3. Thenar space. B. Dorsal space. 1. Dorsal subcutaneous space. 2. Dorsal subaponeurotic space. B. The forearm space of Perron. Pulp space of the fingers. The tips of the fingers and thumb contain subcutaneous fat arranged in tight compartments formed by fibrous septa which pass from the skin to the periosteum of the terminal phalanx. Infection of this space is known as mitlow. The rising in the space give rise to severe throbbing pain. Infections in the pulp space, whitlow, can be drained by a lateral incision which opens all compartments and avoids damage to the tactile tissue in front of the finger. If neglected, a whitlow may lead to necrosis of the distal 4/5ths of the terminal phalanx due to occlusion of the vessels by the tension. The proximal 1/5, epiphysis, escapes because its artery does not traverse the fibrous septa, Fig 9.51. Mid-palmar space and thenar space. Mid-palmar and thenar spaces are shown in Table 9.7. Dorsal spaces. The dorsal subcutaneous space lies immediately deep to the loose skin of the dorsum of the hand. The dorsal subtarsal lies between the metacarpal bones and the extensor tendons which are united to one another by a thin aponeurosis. Forearm space of Parana. Forearm space of Parana is a rectangular space situated deep in the lower part of the forearm just above the wrist. It lies in front of the pronator quadratus, and deep to the long flexor tendons. Superiorly, the space extends up to the oblique origin of the flexor digitorum superficialis. Inferiorly, it extends up to the flexor retinaculum, and communicates with the mid-palmar space. The proximal part of the flexor synovial sheaths protrudes into the forearm space. The forearm space may be infected through infections in the related synovial sheaths, especially of the ulnar bursa. Pus points at the margins of the distal part of the forearm where it may be drained by giving incision along the lateral margin of forearm. Synovial sheaths. Many of the tendons entering the hand are surrounded by synovial sheaths. The extent of these sheaths is of surgical importance as they can be infected, Fig 9.7. Digital synovial sheaths. The synovial sheaths of the second, third, and fourth digits are independent and terminate proximally at the levels of the heads of the metacarpals. The synovial sheath of the little finger is continuous proximally with the ulnar bursa, and that of the thumb with the radial bursa. Therefore, infections of the little finger and thumb are more dangerous because they can spread into the palm and even up to 2.5 centimeters above the wrist. Ulnar bursa. Infection of this bursa is usually secondary to the infection of the little finger, and this in turn may spread to the forearm space of the peroné. It results in an horse slotting, so called because there is one swelling in the palm and another in the distal part of the forearm, the two being joined by a constriction in the region of the flexor retinaculum. It is also called compound pulvinar ganglion. Radial bursa. Infection of the thumb may spread to the radial bursa. Clinical anatomy. Surgical incisions. This section deals mainly with the extensor retinaculum of the wrist, muscles of the back of the forearm, the deep terminal branch of the radial nerve, and the posterior interosseous artery. Surface landmarks. 1. The olecranon process of the ulna is the most prominent bony point on the back of a flexed elbow, Fig 9.1. Normally, it forms a straight horizontal line with the two epicondyles of the humerus when the elbow is extended, and an equilateral triangle when the elbow is flexed to a right angle, see Fig 2.19. The relative position of the three bony points is disturbed when the elbow is dislocated. 2. The heat of the radius can be palpated in a depression on the posterolateral aspect of an extended elbow just below the lateral epicondyle of the humerus. Its rotation can be felt during pronation and supination of the forearm. 3. The posterior border of the ulna is subcutaneous in its entire length. It can be felt in a longitudinal groove on the back of the forearm when the elbow is flexed and the hand is supinated. The border ends distally in the styloid process of the ulna. It separates the flexors from the extensors of the forearm. Being superficial, it allows the entire length of the ulna to be examined for fractures. 4. The head of the ulna forms a surface elevation on the posteromedial aspect of the wrist in a pronated forearm. 5. The styloid processes of the radius and ulna are important landmarks of the wrist. The styloid process of the radius can be felt in the upper part of the anatomical snuff box. It projects down 1 centimeter lower than the styloid process of the ulna. The latter descends from the posteromedial aspect of the ulnar head. The relative position of the two styloid processes is disturbed in fractures at the wrist, and is a clue to the proper realignment of fractured bones. 6. The dorsal tubercle of the rhotis, Lister's tubercle, can be palpated on the dorsal surface of the lower end of the radius in line with the cleft between the index and middle fingers. It is grooved on its medial side by the tendon of the extensor pollicis longus. 7. The anatomical sniff box, Fig 9.33, is a triangular depression on the lateral side of the wrist. It is seen best when the thumb is extended. It is bounded anteriorly by tendons of the abductor pollicis longus and extensor pollicis brevis, and posteriorly by the tendon of the extensor pollicis longus. It is limited above by the styloid process of the radius. The floor of the snuff box is formed by the scaphoid and the trapezium, and is crossed by the radial artery, radial nerve, and cephalic vein. 8. The head of the metacarpal form the knuckles. Dorsum of hand and superficial muscles. Dissection. Make the incision in the center of dorsum of hand. Reflect the skin of dorsum of hand till the respective borders. Reflect the skin of dorsum of middle finger on each side. Look for nerves on the back of forearm and hand. These are superficial branch of radial nerve and dorsal branch of ulnar nerve. The dorsal venous network is the most prominent component of the superficial fascia of dorsum of hand. Identify the beginning of cephalic and basilic veins by tying a tourniquet on the forearm and exercising the closed fist on oneself. The deep fascia at the back of wrist is thickened to form extensor retinaculum. Define its margins and attachments. Identify the structures traversing its 6 compartments. Clear the deep fascia over the back of forearm. Define the attachment of triceps brachii muscle on the olecranon process of ulna. Define the attachments of the 7 superficial muscles of the back of the forearm. Separate the anterolateral muscles, i.e. brachioradialis, extensor carpi radialis longus and brevis from the extensor digitorum lying in the center and extensor digiti minimi and extensor carpi ulnaris situated on the medial aspect of the wrist. Anconeus is situated on the posterolateral aspect of the elbow joint. Dissect all these muscles and their nerve supply. Dorsum of hand. 1 skis, it is loose on the dorsum of hand. It can be pinched off from the underlying structures. 2 superficial fascia. The fascia contains dorsal venous plexus and cutaneous nerves. Dorsal venous plexus, the digital veins from adjacent sides of index, middle, ring and little fingers form 3 dorsal metacarpal veins, see Fig 7.7. These join with each other on dorsum of hand. The lateral end of this arch is joined by 1 digital vein from index finger and 2 digital veins from thumb to form cephalic vein. It runs proximally in the anatomical cioux, curves, round the lateral border of wrist to come to front of forearm. In a similar manner the medial end of the arch joins with 1 digital vein only from medial side of little finger to form basilic vein. It also curves round the medial side of wrist to reach front of forearm. These metacarpal veins may unite in different ways to form a dorsal venous plexus. Cutaneous SRRVES, these are superficial branch of radial nerve and dorsal branch of ulnar nerve. The nail beds and skin of distal phalanges of 31/2 lateral nails is supplied by median nerve and 1/4 inch medial nails by ulnar nerve. The superficial branch of radial nerve supplies lateral half of dorsum of hand with 2 digital branches to thumb and 1 to lateral side of index and another common digital branch to adjacent sides of index and middle fingers. Dorsal branch of ulnar supplies medial half of dorsum of hand with proper digital branches to medial side of little finger, 2 common digital branches for adjacent sides of little and ring fingers and adjacent sides of ring and middle fingers. Dorsal carpal arch, it is formed by dorsal carpal branches of radial and ulnar arteries and lies close to the wrist joint. The arch gives 3 dorsal metacarpal arteries which supply adjacent sides of index, middle, ring and little fingers. 1 digital artery goes to medial side of little finger. The arch also gives branches to the dorsum of hand. 3 spaces on dorsum of hand. There are 2 spaces on the dorsum of hand, dorsal subcutaneous space, lying just subjacent to skin. Skin of dorsum of hand is loose, can be pinched and lifted off. Dorsal subtendinous space lies deep to the extensor tendons, between the tendons and the metacarpal bones, Fig 9.52. 4 deep fascia. The deep fascia is modified at the back of hand to form extensor retinaculum. Extensor retinaculum. The deep fascia on the back of the wrist is thickened to form the extensor retinaculum which holds the extensor tendons in place. It is an oblique band, directed downwards and medially. It is about 2 cm broad vertically, Fig 9.55. G. Attachments. Laterally, lower part of the anterior border of the radius. See medially styloid process of the ulna triquetra and pisiform compartments. The retinaculum sends down septa which are attached to the longitudinal ridges on the posterior surface of the lower end of radius. In this way, 6 osseo-basal compartments are formed on the back of the wrist. The structures passing through each compartment, from lateral to the medial side, are listed in Table 9.8 and Fig 9.56. Each compartment is lined by a synovial sheath, which is reflected onto the contained tendons. Superficial muscles. There are 7 superficial muscles on the back of the forearm, 1 anconeus, 2 brachioradialis, Fig 9.57, 3 extensor carpi radialis longus, 4 extensor carpi radialis brevis, 5 extensor digitorum, Fig 9.55. 6 extensor digiti minimi. 7 extensor carpi ulnaris. All the 7 muscles cross the elbow joint. Most of them take origin, entirely or in part, from the tip of the lateral epicondyle of the humerus. These muscles with their nerve supply and actions are described in Tables 9.9 and 9.10. Additional points. 1. The extensor digitorum and extensor indicis pass through the same compartment of the extensor retinaculum, and have a common synovial sheath. 2. The 4 tendons of the extensor digitorum emerge from under cover of the extensor retinaculum and fan out over the dorsum of the hand. The tendon to the index finger is joined on its medial side by the tendon of the extensor indicis, and the tendon to the little finger is joined on its medial side by the two tendons of the extensor digiti minimi. 3. On the dorsum of the hand, adjacent tendons are variably connected together by 3 intertendinous connections directed obliquely downwards and laterally. The medial connection is strong, the lateral connection is weakest and may be absent. The 4 tendons and 3 intertendinous connections are embedded in deep fascia, and together form the roof of the subtendinous, subaponeurotic, space on the dorsum of the hand. Deep muscles. Dissection. Separate extensor carpi radialis brevis from extensor digitorum and identify deeply placed supinator muscle. Just distal to supinator is abductor pollicis longus. Other 3 muscles, extensor pollicis longus, extensor pollicis brevis and extensor indicis are present distal to abductor pollicis longus. Identify them all. Features. 1 supinator. 1 supinator 2 abductor pollicis longus, Fig 9.58, 3 extensor pollicis brevis 4 extensor pollicis longus 5 extensor indicis. In contrast to the superficial muscles, none of the deep muscles cross the elbow joint. These have been tabulated in tables 9.11 and 9.12. Dorsal digital expansion. The dorsal digital expansion, extensor expansion, is a small triangular aponeurosis, related to each tendon of the extensor digitorum, covering the dorsum of the proximal phalanx. Its base, which is proximal, covers the metacarpophalangeal, MP, joint. The main tendon of the extensor digitorum occupies the central part of the extension, and is separated from the MP joint by a bursa. The posterolateral corners of the extensor expansion are joined by tendons of the interossei and of lumbrical muscles. The corners are attached to the deep transverse metacarpal ligament. The points of attachment of the interossei, proximal, and lumbrical, distal, are often called wing tendons, Fig 9.59. Near the proximal interphalangeal joint the extensor tendon divides into a central slip and 2 collateral slips. The central slip is joined by some fibers from the margins of the expansion, crosses the proximal interphalangeal joint, and is inserted on the dorsum of the base of the middle phalanx. The 2 collateral slips are joined by the remaining thick margin of the extensor expansion. They then join each other and are inserted on the dorsum of the base of the distal phalanx. At the metacarpophalangeal and interphalangeal joints the extensor expansion forms the dorsal part of the fibrous capsule of the joints. The retinacular ligaments, link ligaments, extend from the side of the proximal phalanx, and form its fibrous flexor sheath, to the margins of the extensor expansion to reach the base of the distal phalanx, Fig 9.59. The muscles inserted into the dorsal digital expansions of index finger, first dorsal interosseous, second palmar interosseous, first lumbrical, extensor digitorum slip, and extensor indicis. Middle finger, second and third dorsal interossei, second lumbrical, extensor digitorum slip. Ring finger, fourth dorsal interosseous, third palmar interosseous, third lumbrical and extensor digitorum slip. Little finger, fourth palmar interosseous, fourth lumbrical, extensor digitorum slip and extensor digiti minimi. Dissection. Deep terminal branch of radial nerve, posterior interosseous nerve and posterior interosseous artery. Identify the posterior interosseous nerve at the distal border of exposed supinator muscle. Trace its branches to the various muscles. Look for the radial nerve in the lower lateral part of front of arm between the brachioradialis, extensor carpi radialis longus laterally and brachialis muscle medially. Trace the 2 divisions of this nerve in the lateral part of the cubital fossa. The deep branch, posterior interosseous nerve, traverses between the 2 planes of supinator muscle and reaches the back of the forearm where it is already identified. The nerve runs amongst the muscles of the back of the forearm, and ends at the level of the wrist in a pseudoganglion, Fig 9.60. This nerve is accompanied by posterior interosseous artery distal to the supinator muscle. This artery is supplemented by anterior interosseous artery in lower 1/4 of the forearm. Features. It is the chief muscles of the forearm. It is a branch of the radial nerve given off in the cubital fossa, just below the level of the lateral epicondyle of the humerus course. It begins in cubital fossa, passes through supinator muscle to reach back of forearm, where it descends downwards. It ends in a pseudoganglion in the fourth compartment of extensor retinaculum. Relations. 1. Posterior interosseous nerve leaves the cubital fossa and enters the back of the forearm by passing between the two planes of fibers of the supinator. Within the muscle it winds backwards round the lateral side of the radius, Fig 9.60. 2. It emerges from the supinator on the back of the forearm. Here it lies between the superficial and deep muscles. At the lower border of the extensor pollicis brevis, it passes deep to the extensor pollicis longus. It then runs on the posterior surface of the interosseous membrane up to the wrist, where it enlarges into a pseudoganglion and ends by supplying the wrist and intercarpal joints. Branches. Posterior interosseous nerve gives muscular and articular branches, Fig 9.61. Muscular branches. Before piercing the supinator, branches are given to the extensor carpi radialis brevis and to the supinator. B. While passing through the supinator, another branch is given to the supinator. After emerging from the supinator, the nerve gives three short branches to, 1. the extensor digitorum, 2. the extensor digiti minimi, 3. the extensor carpi ulnaris. It also gives two long, 4 branches. A lateral branch supplies the abductor pollicis 5 longus and the abductor pollicis. A medial branch supplies the extensor pollicis longus and the extensor indicis. B. Articular branches to, the wrist joint, the distal radioulnar joint, intercarpal and intermetacarpal joints. C. Sensory branches. Sensory branches are given to the interosseous membrane, the radius, and the ulna. Posterior interosseous artery. Course. Posterior interosseous artery is the smaller terminal branch of the common interosseous, given off in the cubital fossa. It enters the back of the forearm and lies in between the muscular there. It terminates by anastomosing with anterior interosseous artery. Relations. It is the smaller terminal branch of the common interosseous artery in the cubital fossa. 2. It enters the back of the forearm by passing between the oblique cord and the upper margin of the interosseous membrane, Fig 9.60. 3. It appears on the back of the forearm in the interval between the supinator and the abductor pollicis longus and thereafter accompanies the posterior interosseous nerve. At the lower border of the extensor indicis, the artery becomes markedly reduced and ends by anastomosing with the anterior interosseous artery, which reaches the posterior compartment by piercing the interosseous membrane at the upper border of the pronator quadratus. Thus in its lower 1/4, the back of the forearm is supplied by the anterior interosseous artery. 4. The posterior interosseous artery gives off an interosseous recurrent branch which runs upwards and takes part in the anastomosis on the back of the lateral epicondyle of the humerus, see Fig 8.10. Mnemonics. Anterior forearm muscles, 5 Raphicia group Preti found Pamela for 5 pronator teres. Flexor carpi radialis. Palmaris longus. Flexor carpi ulnaris. Flexor digitorum superficialis. Interosseous muscles. Action of dorsal versus pulvinar, in the hand PSD and dab the pulvinar adduct and the dorsal abduct. Use your hand to dab with a pad. Median nerve, hand muscles innervat the loaf muscles lumbricals. Opponens pollicis. Abductor pollicis brevis. Flexor pollicis brevis. Median nerve exits the cubital fossa by passing between two heads of pronator teres, while ulnar artery passes deep to both the heads of pronator teres. Anterior interosseous branch of median nerve supplies 21/3 muscles of front of the forearm, i.e. flexor pollicis longus, pronator quadratus and lateral half of flexor digitorum profundus. Flexor retinaculum has a superficial slip medially and a deep slip laterally. Deep to superficial slip course ulnar nerve and vessels, and superficial to the deep slip passes the tendon of flexor carpi radialis. Thenar eminence does toy include the adductor pollicis muscle. It comprises abductor pollicis brevis, flexor pollicis brevis and opponens pollicis. Median nerve supplies 5 muscles in the palm, 3 muscles of thenar eminence and first and second lumbricals. It is called laborer's nerve. Median nerve is also the eye of the hand. 5 ulnar nerve is called musician's nerve. It supplies 15 intrinsic muscles of the hand. 6 There are 12 muscles on the back of forearm, 2 are smaller lying in upper 1/4 of the forearm, 5 are inserted close to the wrist, 5 get inserted into the phalanges. All are supplied by posterior interosseous nerve. Injury to the nerve causes wrist drop. 7 Lateral 3 1/3 nail beds are supplied by median nerve and medial 1 foot 1/2 inch nail beds by ulnar nerve.